All right, I think we should probably get started. I'm sure other people will join later on. As we all know, people are busy, so they're probably running to their office to join up. So welcome everyone to this Implementation Science Interest Group for October. This is our second last session for the year. I'm Yvonne Zirinsky. I'm Professor of Health Systems Sustainability at the Australian Institute for Health Innovation at Macquarie University, and a very warm welcome to everyone on behalf of the Implementation Science Interest Group. As you know, this meeting is always recorded and the recording will be available on our YouTube channel. And that allows people who can't attend to actually view it as well, which is excellent. But before we get started, I'd like to acknowledge country. Shalini, if you could. Thank you. So we acknowledge the traditional custodians of the Macquarie University land, the Wallumattagal clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the dream time. We pay our respects to elders past, present and future. And of course, we acknowledge the Aboriginal people and the many lands from which you join today. Let's go to the next slide, please. So, as I said, this is the second last session of the ISIG for this year. Our last session is on the 25th of November, and I hope you find time to join that as well. We have Professor Janet Anderson talking on adaptive teamwork and implementation science at that session. So 25th of November, if you have time, please join. And if not, please watch it online. But today, it's my great pleasure to welcome Frances Barraclough, who is Senior Lecturer at the University of Sydney, Faculty of Medicine and Health. And Frances is located at the University Centre for Rural Health, the UCRH in northern New South Wales, and you'll see from her slides in a minute that that's a beautiful part of the world. Frances leads the development and implementation of an interprofessional education program supporting undergraduate and postgraduate students from up to 15 Australian universities across 13 disciplines. So the UCRH is part of the Commonwealth Rural Health Multidisciplinary Training Program. And Frances teaches over 1,000 undergraduate and postgraduate students each year as part of this program. The program sounds amazing, Frances, and we really look forward to hearing your presentation. As always, please put your questions into the chat, or at the end, there should be plenty of time for a discussion. So please just unmute yourself and ask your question, and let's have a great discussion at the end. All right. So over to you, Frances.
Thank you. Can you see the screen okay now? Okay, perfect. So thank you so much for that warm introduction, and thank you so much for the opportunity to present today. What I'm presenting on, I'm absolutely passionate about, and I hope that that comes across. So the topic for today is a global framework for building our health workforce capacity in integrated care. And as you mentioned at the beginning, I work at the University Centre for Rural Health, which is located at Lismore in northern New South Wales, but I'm employed by the University of Sydney. So before I start, I'd too like to acknowledge the local custodians of the land where I live and work, the Witjabul people of the Bundjalung Nation. I'd also like to acknowledge the custodians of the land where you are all meeting today. So I just thought I'd start and talk a little bit about my role, and you can see there on the map where the University Centre for Rural Health is located. in northern New South Wales. So we're about an hour's flight from Sydney and an hour's drive to the Gold Coast. And our centre services little towns and populations that you can see there, quite remote towns such as Tabulum and Rapville, regional centres such as Grafton and Lismore, and then all of the small rural towns in between. So my background is I'm really proudly trained as a registered nurse over 35 years ago. I am proudly from a small rural town in New South Wales, and I trained in a regional university to do my nursing training 35 years ago. So reflecting back on my nursing journey that I absolutely loved, some of the things that were important to me were connecting with people, connecting with patients, connecting with the community. And back then in those days, people seemed to spend a lot more time in hospitals. So if they came in for surgery, for example, hip and knee replacements, abdominal surgery, people were in hospital for, 10 to 14 days. So during that time, you really got to know people's context. You got to know about their support networks, their families, their carers. You got to know about their health literacy, what they understood about their health, and you were really able to provide, I think, a more comprehensive, holistic care to those people, but also support to their families. So that was one of the things that I absolutely loved about nursing. So I've worked in a few different, I then got a passion for education, and I worked in a few different senior education leave positions. But approximately 15 years ago, I was able to take up this job at the University Centre for Rural Health in a teaching role that I'm very passionate about. And so we are funded by the Commonwealth under the RHMT, the Rural Health Multidisciplinary Training Program. There's approximately 20 university departments of rural health across Australia, and we're one of them. So the Commonwealth funding supports students from universities right across Australia in any of the health disciplines to come to the university departments of rural health for a rich rural placement. At the University Centre for Rural Health, alongside this RHMT program, we also have a medicine program running where we support students from 3 medical schools: University of Western Sydney, University of Sydney, and the University of Wollongong. So those medical students are with us at the UCRH for approximately 1 year, usually in the final years of their medical training. So I'm in a fantastic opportunity where I actually have developed a curriculum and a program for students from across the medicine disciplines, but also across a very broad range of other health disciplines, including dentistry, oral health, physiotherapy, occupational therapy, for example, pharmacy, nursing, all of the allied health disciplines, and I bring them together to train together. So in 2016, we were given extra money by the Commonwealth to expand on our placements for our students. And I can remember thinking back then, most of our students, we place them in acute hospital type settings. And I remember thinking, how can we expand those placements into primary care settings, looking at early intervention and prevention. I also noticed that in the classroom with my teaching, how siloed our disciplines were, how they had little understanding of each other's practice, and how they had little understanding of each other's practice and referral processes, particularly within primary care settings. So in 2016, I had a big role to play in setting up new placements for our allied health students, particularly with a focus on residential aged care facilities in small rural towns with limited to no allied health services. I also set up placements for allied health placements in preschools and primary schools, again in small rural towns with limited to no allied health services. And a big part of this program was setting up the students in different disciplines. So we had students from different disciplines working at these sites together. So alongside that, I also set up what's called the Wednesday Multidisciplinary program, where these students come off placements and they come to the University Centre for Rural Health for a day of training and education together. And I also run a student-led case discussion on Fridays. So back in 2016, when I was part of setting up these programs, I noticed these gaps in training and of the students training in silos, for example, limited understanding of primary care, early intervention and prevention. And I also noticed the speed at which healthcare had changed since my training as a registered nurse. I noticed that we've got an ageing population worldwide. We also have an increase in chronic and complex comorbidities. And people are spending less time in hospital. Care seems to be not on the continuum. It's quite siloed, for example. And so I started thinking about what we can actually do better to train and prepare our health and care workforce to work in this more complex society that we live in. So today I'd like to talk about, I've now developed a global framework for integrated care. So I'd like to talk about what is integrated care, how the framework was developed. I'd like to identify why this work is important, particularly in a national context, and what policies are driving this. I'd like to identify the barriers and challenges to training our health and care workforce in integrated care, talk about some examples of models of training, and describe the key components of the framework. So this work is actually part of my PhD study, which I'm really enjoying because it's so practical and transferable to my everyday practice. And I'd like to acknowledge my key supervisors. So what is integrated care? So the World Health Organization describes integrated care as the management and delivery of health services such that people receive a continuum of health promotion, health protection and disease prevention services, as well as diagnosis, treatment, long-term care, rehabilitation, palliative care, through different levels and across different sites of care within both the health and care system. By health and social care workforce that I'm talking about today, what I mean by that is the different kinds of clinical and non-clinical staff responsible for public and primary care interventions. So the focus is that our workforce needs to manage health and care rather than disease and cure. We need to work in teams across different settings, across different sectors, and acquire a different set of knowledge and skills to enable this. So why do we need an international framework? So although the literature contains many examples of programs of work and training in integrated care in different settings, there's insufficient evidence of what a global framework looks like to guide the education and training requirements to provide this type of care. So how I developed the global framework, which I'll talk in a little bit detail about these steps. So first of all, I conducted a scoping review and this work has been published. So out of that scoping review, I was able to develop a list of competencies, a list of key themes that came out and key features of education and training specific to integrated care. I then completed a modified Delphi study. So out of those competencies from the scoping review, I sent those to where I identified experts from around the world who are teaching and training in this space to look at those competencies and to review them as part of the Delphi study. And then we analysed the results together and came up with the global framework. At the moment, the last part of my data collection for this study is consultation with curriculum leads and policymakers from across Australia to determine how the framework can be used. So far I've completed the interviews and now I'm just writing up that paper at the moment. The Delphi study paper and the framework have also been published. So with the scoping review, what is already known from the existing literature about workforce training and integrated care, that was carried out in 2020. That's the databases that I searched from. I looked at articles if they described an education model or framework or key elements or competencies for health workforce training in integrated care. And you can just see there about how many records we looked at, and 62 in the final part of that review. So what that review showed are some of the barriers to implementing training in integrated care, and this was consistent with what I was feeling in my workplace, training our future health and care workforce across those variety of different disciplines and universities. So I too was finding that curricula for healthcare workers do not promote experience and skills in community and integrated care settings. So students from healthcare learn primary care principles, but then they're placed in acute clinical environments such as hospitals, where it's difficult to implement and practice those skills. And that's absolutely coming up with my interviews, particularly with a range of different disciplines that we're still very much acute focused. So this came out in when I was setting up the placements for the allied health senior students in the school settings, for example, in the preschool settings, in aged care settings. The students have limited to no exposure in those types of settings. So they need to be able to have skills in coordinating care across different sectors is what I'm getting to. So I also noticed for me, and this is coming from the literature, that training still emphasises this diagnosis and treatment of acute diseases. There remains a rigid separation of disciplines at the education level, leading to fragmented learning, fragmented practice, and subsequently fragmented care. Limited understanding of integrated care and the changes required to implement integrated care into the training of our health and care workforce. There's also a lack of access to experts who understand integrated care and who are able to provide this training. There's a lack of competencies and a framework and best practice standards. So the models of training and recommendations that came out of that scoping review that I try to apply to my practice now is involving people with lived experience, including patients, carers, or community participants, in the design, the delivery, and the evaluation of curriculum. So for my Wednesday program, where I bring students together, they're mainly senior students from different universities and disciplines. The types of topics that we cover is understanding national programs in health and care. For example, having a really good understanding of the NDIS and how that works, particularly at a clinician type level, but I also bring in people with lived experience to talk about that. How can we improve our communication for the NDIS participants? We also cover things like the National Digital Health Strategy, understanding and navigating digital health in Australia. We cover things like My Aged Care, understanding and navigating My Aged Care. The students also are on placements in these types of settings that I spoke about, and we've employed a range of really expert clinical educators to support our students in these aged care and school settings. For example, we have OT students, social work students in very remote schools out at Ratville and Tabulum. Nutrition and dietetics, for example, at Aboriginal medical services working together, doing early intervention and prevention work. We have a lot of our students in residential aged care facilities working in different disciplines, and this is really important because of recommendation 38 from the Royal Commission into Aged Care a couple of years ago. That recommendation 38 states that they want aged care facilities to employ a very broad range of health disciplines into the residential aged care facilities. So what we're doing at the UCRH is really cutting edge, because there's been limited employment of allied health disciplines into aged care. So our occupational therapists, for example, in a multitude of aged care settings within our area, are working together with the physio students, the social work students, speech pathology students, nutrition and dietetics within these settings, really leading the way about what these disciplines can do, working together to improve the quality of life for older people living within these settings. So as part of the Wednesday program, not only do they get to hear about a range of national and also statewide programs like New South Wales Cancer Council, what they do to support clinicians, what they do to support people, particularly in rural settings with cancer. They get to understand and navigate a range of different service providers. But the students also do quality improvement initiatives while they're on these placements, and they get to present these initiatives to each other as part of the Wednesday program. So that gives them the opportunity to be innovative and creative on their placements, to really step it up as senior students, and the opportunity to present and articulate their roles within these settings to other students. So as much as possible, I try and involve people with lived experience in the curriculum, and then we talk about what's working and what's not working and how we can develop it and evaluate it. Embedding opportunities for collaboration and learning together with a range of different disciplines and service providers across the health and care sectors. So not only do I invite students to the Wednesday program and Friday student case discussion, I try and invite clinicians from the local health district, professionals from a range of different health and care settings, like the NDIS, for example, like Social Futures, NGOs come, so that we get a very broad understanding of how we can work together, about our referral processes. Also, recommendations from the literature: implement policies for new staff, such as providing an integrated care manual, shadowing opportunities for placement within referral organisations and service providers. Create opportunities for health and care providers to train, think, create and seek solutions together. And that's what I try and implement in my programs at the UCRH. Include training experiences across community and integrated care settings for all health and care professionals. GPs also come and participate in my training, but I'm also trying to get the GP practice staff to come and learn about these different types of NDIS, My Aged Care, for example, and the depth and breadth of the work of our health and care professionals. So as part of the Delphi study process, that just explains how I did that process, the different steps that were involved, and I highly recommend this paper by Nasser et al., which is a 9-step process. So I mentioned earlier, as part of the scoping review, identified gaps in current knowledge of the topic. I also identified what key competencies were in there. Then I used set criteria and strategies to identify and target the panel members from around the world with expertise in this area. I ensured anonymity of the panelists, and I kept providing controlled feedback, iterative rounds to them about the competencies, what language we can improve, how we can improve the competencies, which ones were missing, and how we can put that together nicely in a framework. So why is this work important in Australia? Well, just this year, we've really been grappling with, and well, I've been absolutely contributing to the National Scope of Practice Review for Primary Care for 2024. That final report is due to come out in October, so I'm really looking forward to that. It's a matter of days away. They've released a couple of draft reports this year, and a couple of things that have come out of that National Scope of Practice Review is interprofessional trust and workforce planning. A significant cultural shift is required to embrace multidisciplinary learning, and the need to recognise close relationships between primary care and other healthcare sectors. So the point of difference for my work is that it's not just interprofessional, is that we're working across different health and care settings as well. And it's a big focus on healthcare and wellness. Another big review that's recently just happened is the AMC accreditation review. The focus for that's person-centred care, culturally safe practice, Indigenous people's health and wellbeing, interprofessional practice, and involving community. And then there's the World Health Organization Global Strategy and Action Plan for Oral Health. So this is a big one about training our dentistry and oral health and getting people-centred oral health care, also looking at working across different sectors and disciplines. And I also put this policy in here, and that's the Australian Universities Accord, which the final report was released earlier this year, because I think we need to be training across our vet sector as well as our higher education sectors, because a lot of our health and care is provided by the vet sector trainee workforce, for example, people providing frontline care for vulnerable people like our NDIS clients. Our vet sector are providing frontline care for our residents in our aged care facilities. So we need to be, training together with them. We need to be understanding and navigating about how we can support each other's roles to improve the quality of life for older people or people with disabilities. So I'm trying to bring us all in to train together and work more closely with our TAFE or our vet sector. So the importance of delivering education in regional and remote Australia, big cheers to the Universities Accord for recognising that. I'm proudly from a rural and regional town myself, so I know the difficulties for our younger people if they want to study medicine or dentistry, that sometimes it's just not affordable, or it's out of the question for people living in rural settings. So we need to create better pathways for our secondary school students, for example. Think about transferable qualifications that address our emerging skill needs. And for that, I think it's about healthcare, it's about health promotion. Invest in the teaching workforce, train university lecturers how to teach effectively, employ best practice models in curriculum, which I'm hoping that my work is working towards that. So these are just a couple of quotes that have come out of my recent interviews about why this work is important. Nursing is so acute focused, it makes it very difficult for students to think outside acute care. We're still training our nurses in silos. We tend to operate very much in a silo, and that's historical. We are not taught in our curriculum how to work with other professions. So this is dentistry. There's no structured approach to how we work together in education and practice, dentistry. The health system has done this transition into integrated healthcare, focusing on patient outcomes, the patient experience, but we're not necessarily teaching our students to think along those lines. Best practice standards can guide us in our work, can be used as an auditing tool or when planning new programs, as well as for staff training. So from the interviews as well, I provided the people that I've interviewed nationally in Australia a copy of the framework, and I've asked them about how they think it can be used. And these are some, again, quotes from them as a best practice standard, as an auditing and planning tool. Is this best practice? Where do we fit? Where are we lacking, for example, for planning new programs, to implement integrated care into curriculum, to build staff confidence and implement staff training, to develop champions in health and care environments in the TAFE and higher education sectors, to review or to look at accreditation standards and reviewing competencies and developing postgraduate courses. So a little bit about the framework. So we came up with 40 competencies and 8 domains. So domain 1 really looks at person-centred care. We need to know our people. We need to know our patients, our community. We need to understand the context of where they're coming from. And this is what I'm trying to teach my students or participants in my programs. So if you're a physiotherapist, you need to understand about your person's health literacy, about their context, about their social determinants of health. We can no longer afford to treat a person for their musculoskeletal 40-minute appointment or 30-minute appointment. We need to be looking more broadly about what other care and support they may need, how we can support them to navigate the health and care system. Whether you're a frontline pharmacist in a rural setting, this is exceptionally important. Whether you're an oral health therapist, whether you're a dentist. So really thinking more purposely about person-centered care and how this can be modelled and how this can be provided. Domain number 2 is interprofessional teamwork and collaborative practice. So again, thinking about working across different sectors. I think we do this quite well in the healthcare environment, interprofessional, working across the health disciplines, but we need to think more broadly. How do we work with schools, for example, the aged care sector, the NDIS sector? Domain number 3 is a very important role, is about care coordination. And I just mentioned to you about the physiotherapy role, but let's look at pharmacists, frontline people, particularly in small rural communities. How can they help to navigate and support care coordination across different health and care sectors for people that come into the pharmacy? And in small rural towns, often the pharmacists are the only ones. There can be no GPs, limited to no allied health services. So we need to be training our health and care workforce about care coordination and what that means. Domain number 4 is looking at digital skills and technology. How can we be more up to date? How can dentistry, for example, understand and navigate our healthcare records for all the people that they treat? Domain number 8 is about this big push for health promotion and disease prevention. Are we having conversations every day with our patients, with their families, with carers about health promotion and disease prevention and what's important? Who's responsible for that? We can't leave that to the GPs, who are often pushed for time, pushed for services, limited to no services in some towns. So we all have to take on a responsibility thinking about health promotion, and that's part of my teaching at the UCRH. We need to have a population approach to care. We need to understand our community's needs. And I tell my students when they graduate, wherever they go to work, if that's in a metropolitan setting, a rural or regional setting, understand their population, understand what different service providers are out there. Go and meet the local pharmacists, go and introduce themselves to the local GPs and the allied health providers. Understand about that specific population's need. Domain 7 talks about the leadership competencies and the leadership requirements to be able to enact and to be able to enable integrated care. And Domain 8 looks at the professional and ethical attributes, again with a big push on providing cultural safety, for example. So that's a busy look at the framework, and you'll be able to delve more closely into the framework and also the competencies if you have a look at the paper that I published. So I just wanted to read about domain number 8, which was the professional and ethical attributes. And I just spoke about cultural safety, but there's also about showing empathy and emotional intelligence, practicing reflective thinking and learning, engaging in continuous learning, practicing and integrating self-care strategies. So I see a lot of our students in their final years already experiencing signs of burnout. So we need to be thinking about treating our ageing population and people with chronic and complex comorbidities. We need to be training them and role modelling about self-care strategies. So that's what the framework looks like. I think I'm coming to the end of my presentation. So for me personally, our future workforce needs to understand national, state and local health and care systems and be willing and able to coordinate care amongst these service providers. We need to be able to work alongside and collaborate with interprofessional and intersectorial teams and service providers. We need to know and understand our community's needs, service providers and people's context to deliver person-centred care. We need to involve patients and carers in all aspects of care, in co-designing care and increasing participation and engagement. We need to upskill patients, families and service providers on strategies for health promotion and disease prevention. We need to manage people's health and care rather than disease and cure, and to provide skills for people to engage with the technology, including clients, service providers and health and care workers. We also need to value continuous learning, as our health workforce are our future leaders, mentors and teachers. So that's some of the references there, particularly to the scoping review, the Delphi study, which has the actual framework, and some of the policies that I was referring to earlier in the study. And I think that's all from me. So thank you so much.
Fantastic. Thank you so much, Frances. That was really amazing. And what great work you're doing, and clearly super passionate about what you're doing. Are there any questions for Frances? I'm sure there are many. Perhaps I'll kick off. So the work that you're doing in the sort of, tertiary training sector is super important, but you did mention that things can unravel a little bit when the poor students become professionals in the system. So if you were to change one thing about our healthcare system to improve integrated care and interdisciplinary ways of working, what would that be?
I think that would be providing more opportunities to train our health and care workforce together.
Mm-hmm.
Not only the students, but I also have invitations for participants to come to any of the programs. So not training in silos, but training us together.
Yeah, and I guess training the people who are already in the system.
Absolutely.
And very much used to working in a siloed way.
Yeah.
And
just one thing I did mention, and that's the student-led case discussion on Friday. So between 12:30 and 1:30, I facilitate students to present. It used to be called the hospital grand rounds, but it was mainly attended by the medical professions, who rarely talked about people, patients, social determinants of health, carers, support, people's context. And so I am now trying to empower my students, not only across medicine, but across the allied health professions. I've had dentistry students present, nursing students, when they are presenting, to talk about people, to talk about their context, to talk about their goals. Who are these people before they presented to the GP or came into hospital? So they do this very holistic presentation. I also bring in people from the social care sector or experts from across Australia. So this presentation is face-to-face at the UCRH, but I also have the opportunity for people to attend on Zoom every Friday from 12:30 to 1:30, and I often get people from across Australia. And I invite experts, like someone from the Transgender Centre in Sydney, if we're talking about how we can communicate and better support people from different genders. So I get experts to come in on Zoom to help us to navigate that. So it's a different topic every week. It's really fantastic. The students learn so much. So that's
wonderful. I think Steph had a question.
Yeah, no, mine wasn't so much a question, more sort of like agreeing with sort of what both you, Yvonne, and Frances are saying. So I'm based at the University of Melbourne, and so a lot of the students there are in the School of Health Sciences. So we have audiology, speech, physio, sort of all the health sciences that you would expect to find there. And yet, as you say, they're all trained in their individual areas. And of course, we need people to do the physio bits they need to do. We don't need the pharmacist to become a physio, sort of a specialist physio, and vice versa kind of thing. But there's some stuff, isn't there, that are around research methods and I don't know, consent and all of those kinds of things, that actually we need them to come together, and we don't need to be repeating this 10 different times across 10 different disciplines.
Yeah.
Not only is that wasteful, but then it's kind of that missed opportunity to be bringing all of those students together at that early stage. It just seems like a no-brainer to me.
Yeah, absolutely. I agree. And the students can be really innovative thinkers together, creative and innovative. Like, you think, wow, this is so powerful in the classroom, and it makes your teaching far more enjoyable as well.
Yeah, absolutely. So you're obviously based at the in sort of the rural health setting. Do you see any appetite for this to be transferred and generalized across other areas?
Absolutely. So on Fridays, I have a lot of health science students from University of Sydney who are doing honours projects join in. So they might be looking at a drug for pancreatic cancer, and presentation might be about manage a patient with pancreatic cancer. So I might have 20 students joining from health sciences. At University of Sydney, social work is very separate from the faculty of medicine and health. So bringing social work in to understand and work together has really been brilliant. I do see this as an opportunity for metro centres to describe my training and how this can be done and how it can be implemented. I think we've been doing pockets of interprofessional learning for a long time now, for many, many years, but I don't think it's very acute language. It's acute focused.
Yeah.
It's about multidisciplinary teams working in hospital settings, but I think we need to get it out of hospitals. I do think the work in acute care is exceptionally important. And as you said, you know, all those physio and discipline-specific skills are really important as well. So I'm not taking away from that, but we are working with ageing population and chronic and complex conditions. So we need to know about each other's roles. A role that's not well understood is exercise physiology, for example.
Yeah, absolutely. How do you find all integrated teams work differently? So I'm a physio by background, so I've worked in lots of different integrated teams sort of over the years and in different countries and different places, and they all work differently. How do you find people transfer from sort of one integrated team or one setting where they've been working in an integrated way into another setting?
Well, I think it's about empowering people with the skills that you need. So when you go to work in a different setting, as I mentioned earlier, look up who the local GPs are. Go and introduce yourselves. Introduce yourself to the pharmacists, the key pharmacists, for example, that you'll be working with. So that if you do want to pick up the phone and talk to the pharmacist about, as a physiotherapy, that you're worried about some polypharmacy for your patient, you can easily do that. You feel very comfortable about that. So teaching transferable skills. Sorry.
No, I'm totally agreeing with you. But I was going to say, all of those things take time. And so they're really, really important things to do, but they're not the metrics that people get measured by, are they? They're measured by how many new patients have you seen, and what's your new follow-up rate, and all of those kinds of questions. Yeah. So how do we now go on and maybe push this up to a policy level to say, absolutely, key performance indicators, we get that, but actually we want that quality of care and that patient-centered care, as you were sort of saying, as your sort of number one domain. How do you think we can go about doing that? Yeah,
sharing stories, sharing and publishing this research, presenting to policymakers. That's where I'm at the moment. I really want to get this across the line.
Yeah.
There's the World Health Organization policy for oral health that I spoke about that's just come in 2023 to 2030, I think it is. So oral health and dentistry, big push for this. And I was talking to a senior dentist as part of my research, you know, a couple of weeks ago, and they say that, you know, when they're supervising students, dentistry students will say, I've got a patient coming in for a 212. You know, they don't even talk about their names. It's the procedure. It's a 212. I can't see any problems with, you know, any of the patient's medications or anything. Everything's right to go. But then when you look at that patient behind the scenes and you look at their complex comorbidities, you think, well, there's a lot more than what the dentist can be doing here. So it's about changing mindset, changing practice, looking at things differently. We've got a long way to go with upskilling our supervisors, For example, nurses are trained by nurses and supervised by nurses, but we've all trained in acute care settings. So we don't understand this, and it's busy in these settings. So a long way to go with training up champions to understand this work.
Are there any other questions from other participants? No. In that case, I will follow on with the track that you're on. Of course, to do this and to understand the sort of individual context and to, address the context within which people live and determinants of health requires a lot of time and capacity. And that's something that the system is really struggling with at the moment. As we all know, we have a global health workforce shortage. And nowhere more so than in northern New South Wales. I've done some work with the Northern PHN up there and the LHD, and workforce shortages are really, really biting them at the moment. So how do you see building that capacity to be able to do this in an integrated way and actually, do it in a meaningful way and address determinants of health and work across sectors? How are we going to do this when we can barely keep up with the acute?
Yeah, that's a good question, Yvonne. Solutions for that, but I think role modeling the work, presenting the work, getting our, new and emerging health workforce at least to understand the importance of it, and also taking the pressure off GPs, for example, so that we can navigate and refer our patients across a very broad range of service providers. So last Friday, the case discussion that we had was led by a couple of our students from University of Wollongong medical students, and they spoke about functional neurological disorder. So they spoke about what that is, how it's diagnosed. It was a fantastic presentation. But they also spoke about the range of different support options available for patients, the assessment tools that are available for clinicians, the support that's available for GPs through different associations like functional, national associations. So the more we know about those, the more we know about the depth and breadth of the work of New South Wales Cancer Council and how they can help support people, patients, families, as well as clinicians. So the more we can get that into our training, the better.
Yeah, there's also a new workforce coming up through the ranks, and they're called social prescribers or LIC workers, and they work in between the sectors and in between health and social care. So, developing and supporting that workforce might also help. But I see that Milena has appeared on our screen. Milena, do you have a question?
No, I don't have a question, but I think it was a really good point to raise the neurological disorders, because I know you mentioned dentistry, but the WHO also has an intersectorial IGAP plan for neurological disorders and is really pushing a lot of this stuff as well. And I'm a clinical psychologist, so a lot of determinants of health and formulating patients is just kind of what we do. And I think there's a lot of value that psychology can have for particularly clinical health psychology for formulating patients and kind of training across multiple disciplines. I really agree with it. Kind of can start with training, like shared training, to see the patient from a more holistic perspective, but also to speak to that point about, we're already stretched in terms of a health system. The way, and sometimes the only way people listen is if you show that this stuff is cost effective. So a lot of where the integrated psychological care, particularly some of the stuff that I've looked at of colleagues doing overseas, is where they'll have a psychologist on a neurology team and show basically that it will save money. There's good examples in Scotland where neurologists will screen children and then they have a psychologist, and it reduced CAMS referrals by like 60%. So the NHS now funds that model, and the only way that they could really do that is to show that it's cost effective. So I think that's, as well as presenting and research, if we do have those projects that show that it improves quality of life, which is incredibly important, but is probably not enough to shift policy. We also show that it saves money and there's going to be less emergency visits and the comorbidities and blah, blah, blah. That's the only way we're going to probably get more traction. Yeah.
Yeah, absolutely.
Any other comments or questions for Frances? Yeah,
Just one
Andrew.
question. Thank you. That was so interesting. I really appreciate it. And I'm always interested in competency frameworks. We've got one in evaluation ourselves, and I was just wondering if you've received any feedback on the framework yet, whether it's to do with content, whether it's scope, whether it's the size of the framework or its accessibility. Any feedback so far?
Well, the feedback I have is from participants that I've been interviewing, usually academic leads or policy leads from across Australia. So this is the feedback about how the framework they thought can be used. This is direct from them. So developing postgraduate courses, reviewing competencies, planning new programs, comparing our own programs with best practice, for example, or accreditation requirements.
If I could follow on that, Frances, I think you mentioned this was meant to be a global framework. So are you leveraging your links with the International Foundation for Integrated Care? I noticed Victoria Stein is one of your supervisors. Is that an idea to bring this framework out through the International Foundation, or?
Oh, absolutely. I'm a senior associate for the Foundation of International Foundation of Integrated Care. I'm part of the editorial board for the journal. I am so passionate about working with that whole, leadership team. And the scoping review was international. The Delphi study was international, but just to get on with my PhD and try and keep it a bit more realistic for translation into Australia, I chose just to interview for Australia, but I have been working with the director for IFIC just this year, looking at the gaps across different countries in education and training and contributing to that piece of work as well.
Yeah, fantastic, because it would be great to leverage what you're doing in Australia internationally.
Absolutely.
Yeah.
Thank you.
All right, we have 4 minutes. Any other burning questions for Frances? Or comments? If not, I think we might just finish up. Thank you so much, Frances. It's been lovely meeting you and listening to you talk about your amazing work. Thank you so much, and please spread the word to others. This will be available on our YouTube channel, and I think there's a lot to learn from this presentation today. And hopefully we will see you on the 25th of November for our last session for the year. Thank you so much, Frances.
Thank you. Thanks for the opportunity, and please reach out if you'd like to know more information about the work or the programs that I deliver.
Yeah, absolutely. Thank you.